I'm Chris. I'm a family doc trained and then did my merge and work in Calgary and work at the Foothills and Peter Lahi there. So does everybody have a smartphone or laptop with them? Smartphone, please.
Yeah.
Perfect. Okay, so this talk's going to be like half me talking and then half you guys making sure you have everything. Okay? So the conflict of interest slide that's obligatory. I have no financial conflicts of interest. I've never been paid, I don't think, to do anything other than work at the Foothills.
Hopefully.
Yeah, I get paid to work. So. Non-financial, I am a proud supporter of FOAM, so free open access medical education. I am fully invested in it and think it's awesome. I podcast for the SGEM with Ken Milne about once every 2 months. I have my own blog, socmob.org. I'm the social media director at the University of Calgary, and I was the social media director for CAPE 2018. So, okay, very good. Okay, so everybody basically does some emerge, which is great because FOAM is pretty much spearheaded by the emergency docs of the world, a little bit the anesthetists and critical care people as well, but it's mainly an emerge thing. And so I think that FOAM is super valuable when you're somebody who works in a tertiary care center like I do, but I think that FOAM is actually much more valuable to people who are not working in tertiary care centers. So people who don't have residents constantly being like, hey, look at this journal article, or, like, what do you think about this esoteric disease? FOAM is much more valuable when you're on your own and you need some resource right now, anytime, any place, for free. And so I think that this is a great audience for it. So we're going to talk about a few objectives. So using FOAM effectively is what the goal is today, because there's tons of it. Okay, so this is through high quality curated blogs, using an RSS reader. So let me just ask, who's using an RSS reader? Sweet. Who's using podcast app? Okay, good. Who's using Twitter? Nope. Okay, who uses Google FOAM or knows what it is? Great. All right, who has any storage resources that they use? What storage resources do people use? So how do you store good information when you find it? Like, oh, I found this great guideline. I want to keep it in a place where I can access it easily whenever I need to.
I use it like a bookmark.
Yeah, awesome. Okay. And then we'll talk about storage resources, and then we'll talk about FOAM quality, because quality is always the caveat, right? The buyer beware of everybody's criticism of FOAM is about how good is it? And then we're going to have hands-on time, which is going to be like the last half hour. So I'm sure many people have seen this quote. This is Joe Lex, one of the great EM educators of the world. So if you want to know how he practiced medicine 5 years ago, read a textbook. If you want to know how he practiced medicine 2 years ago, read a journal. If you want to know how we practice medicine now, go to a good conference. And if you want to know how we'll practice medicine in the future, use FOAM and talk in the hallways. So the story of FOAM, since some people say they're FOAM illiterate, the story of FOAM, this came up really, it's been around probably about 13 years, but it came up in 2012 at ISEM, which is the International Conference on Emergency Medicine, and that was in Dublin.
I was there.
Yeah. Were you at ISEM?
Yes.
Were you at the conference? Were you at the table?
No.
Oh, that's,
I might have
I was
gone
like,
to just
you
a
might
little
have-
bit of the conference and a lot of Ireland.
That's a lot of Ireland.
Yeah, sorry.
Okay, so you were there when FOAM really came to fruition. So Mike Cadogan, who's an Australian guy, he's the guy who basically, him and Chris Nixon, began life in the fast lane and are still the people responsible for it. They talked over beer, and that's where the FOAM comes from. And there were a bunch of other emergency medicine educators and critical care guys there, and girls as well. And really it was the idea that medical education should be available for anyone, anywhere, anytime. And it's not just a community of practice, but it's an ethos, really, okay? So it's independent of platform, whether it's Facebook, Twitter, Google+, photographs, blogs, podcasts, anything else. FOAM is just free and open access and available. But the problem is there's now a huge amount of it. So we have to learn how to filter our resources so that we don't have information overload and have this all work against us. And so for me, I learned by FOAM. So I started practice in 2013. I don't have up to date. I work permanent nights at the Foothills and Peter Lahi. And I feel like I've kept pretty well up to date. I don't have any resources that I have MRAP, I guess, which is a paid non-FOAM resource. That's the only thing I have for continuing medical education that I really pay for.
It's not free.
Yeah. So, I think that FOAM can make you a better clinician, can keep you super up to date, with everything that's out there. And then if you're talking with other people about it on top of it, or just conversing via Twitter with people who are experts in fields, you can keep it very up to date. So this is just a little bit talking about the most successful civilizations in human history and human development over time have been those that were the fastest to communicate. We began with gestures, then spoken word, then we passed down our histories orally, then we started writing things, then we got the printing press, and then we got a computer and the internet, and now everything is available at the touch of your fingertips, right? But some of the people who really did a lot of the learning and teaching were criticized a little bit, to be honest, for it. So whether it was Socrates because he didn't write anything down and he felt that you shouldn't write anything down, and then he passed it on really to Plato, who started writing things, and then Aristotle started mass communication. And then later on, universities really looked down upon the penny universities of the 17th century in England and the salons in the 18th century in France, where people would buy a cup of coffee for a penny, and then you could go in, you could smoke cigarettes, you could read newspapers, you could cut up live dolphins on your table in these places. Isaac Newton did that. And these were places where a huge number of the most influential people in history with regards to philosophy and science did a lot of great creation of communication and ideas. But it wasn't a university. These were coffee shops, right? And foam is kind of similar. It's somewhere where a lot of people who are very brilliant people are talking, but we look at it sometimes with a very skeptical eye, which is a good thing, but hopefully down the road we're going to look at it with a really positive eye. So I'm going to go with some statistics to start off with, just so that we know where people are at. So I still believe textbooks are very useful. Okay, I don't think foam is the answer to everything. I think that everybody needs foundational knowledge. Okay, I read Rosen's, I read Tintinelli's. That's critically important stuff. But we need to know who our learners are and what they're invested in, right? So this is a survey from 2014 of 420-ish emergency medicine residents in the United States. And they found that about 70% of them felt podcasts were helpful, 54% felt textbooks were helpful. So if they're not invested in buying in, unlikely it's going to be helpful. Similarly, 36% of them found that journals were useful. So another survey, this was done by Eve Purdy, who's a resident in Queens. This was in 2015, showed that 90% of residents are using podcasts each month, 86% are using blogs, 71% are using podcasts. Okay, so this is basically out there, it's being used, so we better learn what's good and where we can direct people, right? Because otherwise they're just going to be coming up to us and saying, hey, I heard this thing, I'm going to do it. And you're like, whoa, I never heard that before, that sounds crazy, right? So Life in the Fast Lane keeps track of the emergency medicine critical care blogs out there, and as of 2018, there are about 325-ish emergency medicine and critical care blogs. And we've kind of reached this kind of flattening off in the slope here now. So it went crazy. And there was this huge growth between like 2012 and 2016. And then people realized like that's just too much information overload. Some of them weren't getting enough traction. You can only pay attention to one or a couple or 10, if you're somebody who does this with a lot of passion. So now what's happened is a great thing, which is consolidation of a lot of these really good ones. So a lot of people have come together, and I'm going to show you a lot of those blogs where 4 or 5 or 10 or 20 people have come together to create higher quality content than we ever had before, and stuff that is published now on a more regular, nearly daily basis. And the other good thing is about 90% plus of them have legal disclaimers now, which is good. And many have peer review, basically, where they get an expert on the topic that they've written something on and actually get them to review their posts prior to putting them up. So we're dealing with information overload for sure. So we got 300 blogs and podcasts. How are we going to keep up to all these things? That said, as of last year, there were 72 acute care emergency medicine journals out there. So I can't keep up to that at all. And I need a filter for anything I do. So we need filters for foam. And apps and devices help us with this. So I'm going to start off. So I sent you all a handout. If you were on the pre-thing, you all got an email in the last 30 minutes with a handout that has all the stuff I'm going to talk about on it. It's a 2-page handout, okay? So if you weren't on the if you weren't originally attending this session and didn't have your email, I'll send it to you after if you give me your email, okay? So I'm going to talk about each one of these blogs for like a few minutes, or a minute. So Life in the Fast Lane is kind of the thing that started it all. So Mike Cadogan, Chris Nixon, a bunch of other authors. This is very emerge medicine, critical care focused. They also do peds emerge, toxicology, and not so much the things like wellness and things like that. It's very, they have an ECG compendium, they have a toxicology conundrums, they have something that's really great called the Life in the Fast Lane Review, which comes out once a week and has a bunch of really good emerge docs from multiple continents who review all the foam that week and say these are the best foam posts on blogs anywhere this week. If you just use that one thing, that's like the place to start probably. Just start with the Life in the Fast Lane Review. You can also use their research and reviews, which does the best articles that were published that week. Academic Life in Emergency Medicine is the other big gun. Okay, so this is Michelle Lynn's baby. Has probably 20, 30 plus authors now. They publish in a very systematic style. So Monday through Friday, they publish something on a specific kind of area. So Monday would be like a medical expert area. Tuesday would be a research study area. Wednesday would be wellness related, that type of thing. So they a little more diverse, really good authors. Then another day it might be pharmacology or something like that. So a great site. St. Emlyn's is a bunch of British dudes, Simon Carley and friends. Again, they focus on journal club type stuff, very critical appraisal based, but also publish on a near daily basis, and a bunch of guys. Rick Body, who's like the troponin master, publishes on St. Emlyn's. So I'm in like Journal of American College of Cardiology 2013 Rick Body study, beyond there before anything came out elsewhere. So you'd be able to ask him questions about his study on high sensitivity tropes. MCRIT, so most of you know MCRIT probably as a podcast that's very critical care focused, airway, trauma, right? All that kind of stuff, not really any softer side things. But it's actually now a very good blog. So Scott Weingart, who had the podcast, actually now has Josh Farkas, who is from the Intensive Care Network in PulmCrit, so he's a pulmonologist. He has his own section on the blog. There's the Talks and the Hounds guys who just do talks on the blog. There's Rory Spiegel, who had a great blog called EM Nerd, and he just does critical appraisal. He's on there now. And then there's Paul Merrick, Paul Merrick is like the 7 standing mares guy who always has a totally different idea of sepsis and other things. He's an intensivist than a lot of contemporaries do. And it's really neat to see the balance of like Paul Merrick stuff and Scott stuff on the same blog. So it's now a freestanding, very good blog in addition to being a great critical care podcast. Canadian is Brent Toma and friends in Saskatchewan and across Canada. Very similar to Academic Life in EM. Very similar model, publishes Monday to Friday. They also have Crackcast. Does anybody know that one? It's a podcast that reviews every single chapter of Rosen sequentially and is very good. There's a 30-minute chapter on each chapter of Rosen's. I listened to 2 pediatric ones on the way here. Carl Phillips does them from Calgary. Rebel EM is Salim Razai. Again, I posted on Rebel EM, really good consolidated resource. Core EM is Anand Swaminathan's really good consolidated resource. These both have a lot of resonance, posting, and that type of thing. And then First 10 EM I'd really like to highlight because it's Justin Morgenstern, who's a Canadian emerge doc out of Toronto, now living in New Zealand. And he does a ton of stuff on wellness, on performance in high stress situations, also critical appraisal and that kind of thing. He also does the SGEM with me and Ken. And then there's a few pediatrics ones down at the bottom for people who do peds. The PEM blog is great. Trek is really good. I won't spend quite as much time. So now that I've highlighted all these great resources, how are you actually going to figure out what to do with them, right? You're going to go and check every website every day? No. Big waste of time. Is there a new post? Blah, blah. No. So you're going to get Feedly, or some type of feed aggregator. So an RSS feed app. And we're going to, later on in the hands-on time, we're going to get you to all get one of these. Okay? So you're going to download Feedly, which is a rich site summary aggregator. And what these are really designed for originally is like newspapers. So you could get like the New York Times, and you can get the Washington Tribune, and da-da-da. And what happens is it auto-populates a feed when you sign up for it. So you sign up for Life in the Fast Lane, and then every time a new post comes out, it's just auto-synced. And you open it 10 minutes a day or whatever, and you just see which ones have new posts, and you just flip through it like magazine articles. And you say, oh, that post title is interesting to me, like this newspaper or magazine article. I'll read it. And you just click on it. Oh, this one's not interesting, swipe by it. And so you can add on which feeds you want. So you can add on Academic Life and Life in the Fast Lane. And I suggest you start with like just a couple of them, and then you see if you're using it, and you just make like 10 minutes dedicated time, like when you're eating breakfast or whatever, if you get to eat breakfast, and you just read them at that point each day. I'm going to talk about one other non-foam resource, which is QXMD or QXRead. Does everybody know this one? Okay, so this one is not foam again because it requires an institutional subscription or login in order to actually get access to the primary literature articles. But basically what it is it's really good. This is QXRead and this is PEM database. They're two different things. QXRead or QXMD allows you to compile primary literature papers in your areas of interest. So you can just click like, I'm interested in family medicine, emergency medicine. Only those ones will populate, and then ones that are the most popular will kind of work their way to the top. And if you use the U of C institutional login and you just link it to your app, you can just click the paper and it opens up the paper and you've got it. So super nice. But again, it's not foam. PEM database does the top 38 pediatric emergency critical care journals, and you can just search those 38 through the PEM database. Again, not foam, and you have to go then find the article, but they're good. So podcasts that sound like
Why 38? Just
that's how many they have.
Sorry. Oh, okay.
That's just a number.
Odd number.
I don't know, I like numbers.
Oh, fair enough.
I'm just weird that way.
That's right. Just not really interesting.
So podcast app. So it sounds like everybody's got a podcast app. Yeah? Awesome. Okay, so don't download podcasts individually. Get a podcast app. Done. That's how you can spend all your commuting time. So MRAP, I'm not foam, but I'm a good CME. I cost $400 a year. US, so I cost $500 a year.
Yeah.
But there are other ones that are awesome out there. So some podcasts to follow. Do people follow emergency medicine cases? Yeah, it's great. This is Canadian content, so Adam Hellman out of North York. He gets a ton of great guests, actually basically the same guests that MRAP gets, also lots of great Canadian guests. And it's free, and they're usually 1 to 2 hours, and they're very practical, quite thorough. Don't have any of the CYA medicine garbage that MRAP has that we don't need to deal with, to be honest, and skip over an hour of MRAP every month for. Skeptic's Guide to Emergency Medicine, so clearly self-promotion a little bit, conflict of interest. This is for people who want really one article critically appraised well. That's what the Skeptic's Guide is about. It's not about like, here's an overview of a topic. Each week it's a clinical question, the article that answers the clinical question, critical appraisal of that article, and then often having the author of the article actually on the show and asking them the questions that we want to ask them about the article that we thought were not clear in the article. So very useful. Foamcast is Lauren Westford and Jeremy Faust. It's more of a jump around half an hour podcast, but very good and very EBM. And they kind of will jump from all kinds of things, from airway topics to sore throats to medications safe and lactation and all kinds of different things. They're a little all over the place, but very good. The Crackcast, so covers each chapter of Rosen sequentially, covers each one in about 30 minutes. Obviously, you can't cover a chapter of Rosen in 30 minutes, so it's sometimes the danger is a little bit superficial, but man, it's a good intro to a lot of things. And if you want a refresher on some stuff, it's quite good. MCRIT, all airway trauma, ECMO, Reboa, things that we're not going to do, but very good. PEM Currents, and I didn't have it on here, but the PEM Playbook, Pediatric Emergency Medicine Playbook, probably the two best pediatric podcasts out there. And, I will put in a plug I didn't put on here either. You guys know SmartEM? Okay, so SmartEM is probably the best podcast ever. Unfortunately, David Newman turned out to be a very terrible person. So people don't really talk about it anymore because he's a terrible person. Doesn't mean they were 2 hour to 3 hour in-depth podcasts on sore throat and why you shouldn't treat it with antibiotics in first world countries, right? Who cares about strep? It completely changes your practice. These podcasts, 3 hours of why I will never treat strep throat with antibiotics again, because rheumatic fever just doesn't exist here, right? And so they're fascinating, or why you can put epinephrine in digits, or why statins are bad, and all kinds of great things. So phenomenal podcast. He's also the guy, do you guys know the NNT.com? Yeah, so Dave Newman created NNT.
Oh.
which is also a great resource on shift. And number- Smart EM. Yeah, if you guys get Smart EM episodes, like they're crazy in depth. Like what he does is he goes back to like the pre-radiographic literature on Salter-Harris 1 fractures and talks about it. And then he does like every paper on Salter-Harris 1s from the beginning of time. And it's like, we clearly don't care about Salter-Harris 1s, right? And it's just like, wow, it's like 3 hours on Salter-Harris 1s. You're just like, it's just fascinating. And so he's a terrible person. His podcast is awesome. You guys can also read up about why he was a terrible person. So that'll also be some fun reading material. So then we'll talk about Twitter and social networks. So Twitter is a microblogging platform. So formerly 140 characters, now bigger and better, 280 characters per tweet. And so the key with Twitter is signal to noise, right? The key with all this stuff is signal to noise, but Twitter especially. So you can have a ton of noise if you follow lots of people, or you can follow like one thing that's very good and get lots of signal, right? So you follow who you want. And the reason why it's good is because it's the most commonly used by the people who make foam. So people who make blogs, make podcasts, usually publish their stuff on Twitter first. And so over 80% of blogs and podcasts have Twitter accounts. Whereas compare that to like Facebook or Google Plus or stuff, it's far less than 50%. The best part of Twitter, though, is that it eliminates that previous one-way flow of information that we've had forever, right? Textbooks, encyclopedias, podcasts, they're all one-way flow. You're sitting there, you're listening, you're sitting there, you're reading. You have a question, you can't have an answer, right? Twitter eliminates that problem. It's two-way flow of information. So you can directly contact the person who made whatever they made and say, hey, I have this question about what you just did. And they'll reply to you, and it's great. And you can ask like world experts questions on things, and they'll reply to you. So for example, like the Penn Emerge residency has a question about PE for superficial clots. So they asked Jeff Klein, who wrote the PERC study and every DVT study in the last 15 years. And Jeff Klein says, here's my answer. And then they know, right? Like that's pretty awesome. That's something that just doesn't exist with previous forms of knowledge dissemination and knowledge translation, right? Or, for example, Ian Steele. Ian Steele's on Twitter, probably the most famous Canadian emerge researcher ever. And these people have a question about NOACs versus warfarin, and Ian Steele says, oh, here's my answer, this is what I do. And so these types of things kind of really change the game when it comes to knowledge translation. So I suggest everybody downloads the Twitter app or uses twitter.com, makes a profile, and is identifiable, but you can just keep the egg picture and you can make no profile. Following people is good. If you contribute, that's better, and be professional. But I'll go through a quick kind of Twitter lexicon, just so that everybody has it. Because nobody put their hand up when I said Twitter, right? One. Okay, perfect. This will be super redundant.
I'm an old man. This is very helpful.
Okay, perfect. So handle is your username. Tweet is a 280 character message. Retweet is resharing or giving credit to someone else's tweet that you found particularly helpful or that you think other people who follow you should see. Feed is your home stream of tweets. Okay, so anybody you follow, so this is following versus followers, so if you are following, these are the people whose tweets will show up in your feed, and you'll see them. If your followers, every time you tweet something, that will show up in their feed. A hashtag is basically a way of denoting a topic of conversation in a larger discussion. So the big, most common FOMED ones are hashtag FOMED and hashtag EMConf for EM conference, or you could have like hashtag fake news, you know, like everything. Because Donald Trump, yeah, now that Donald Trump uses Twitter so much, I hate it more. Because, you know. And so mentioning somebody is you put @ and then their handle name or their username so that you make sure that they see the tweet you sent. And then direct messaging is if you want to send something that the masses can't see, but you both have to be following each other in order to do that. So you can literally start by just following @foam_highlights. If you make an account, which we'll do later, follow @foam_highlights, and they're just a conglomeration of like 30 good foam resources, and they just post each time something new comes out. It's a good thing that might be interesting from a foam perspective. And you could just have like one thing. You could also follow like Mike Cadogan's sentence, or for Alien Team is really good. So these are people who don't have noise in their feeds, okay? Aaron Johnston, you can follow. He's the director of this whole thing. You can put him on there. And the best way to find foam stuff is actually if you just put in the search bar, you just put hashtag FOAMED, and you'll just find like amazing stuff that's totally fresh and new and interesting. So, customized search engines. Anybody use Google Foam or Foam Search? I saw no hands. Okay, so Google Foam, so you can make customized Googles that search only things that you want them to search. So Google Foam is a Google that searches only foam resources. So it now is, if you type in Google Foam, it redirects you to foamsearch.net. This was created by a Canadian emerge doc, Todd Rain, who works at, I think, Royal Columbia. And basically, if you're like, I know I saw something on some blog somewhere that was really good about this topic, but I don't remember which one it was or whatever else, you go on Foam Search and just type in whatever your search term is, and it'll just come up with foam resources that were about that topic. And you'll usually find what you needed to find. So it's a specific search for emerg med and critical care cases. Okay, so now that we're done with that, I'm going to talk a bit about storage, and then we get to the hands-on time. So, storage. So people when they respond to the survey told me they're using like iPhone notes or bookmarks or something to store when they found something interesting. I feel like there's a better way. So does anybody use Evernote or OneNote? You know of it?
It's there.
Yeah, it's there. Okay, so Evernote is super good. OneNote is super good too. They're both great. Evernote is free on 2 devices, so you can have it on your laptop plus your main phone. If you want more devices than that, you have to pay like a couple bucks a month. I just use the free version. OneNote you can get, I think, through, if you guys have the University of, so it's free, but you can also get like the better version of it through OneDrive through the U of C. So you can, I'm sure that many people in this room can get that, okay? And it's available on like all devices. So I'm going to just show you quickly how this would work, okay? So, for example, I have, say I'm going to just show you my Evernote. So my Evernote looks like this. So you can make notebooks that are individual and stuff. So here are my notebooks. Okay, there's a bunch of Nadim's notebooks, and there's my notebooks, and then there's like FR emerge review notes, and then passus verbis cards. So like the FR review notes are basically every chapter of Rosen's in a review form. If I ever need to pull up something, I just like, here's my aortic dissection one, and you just boop, 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 and you just, there it all is, right? So it's all in there, and it's all on my smartphone if I ever need it. Okay, or PE trial, so a bunch of articles that you want to throw in there or whatever else, right? So you can search it by all notes, or you can make it like peds, adult, family, da 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 da, optho, all this kind of stuff. So then let's just say we want to make a new note. So say I go to the Skeptic's Guide to Emergency Medicine here. Let me go back to the introduction. So recently there was a podcast a couple weeks ago on the hour rule, which is like a opioid observation after reversal with naloxone. I go and get this nice free open access paper from Academic Emergency Medicine from December 28th, 2018. Download the paper. And then, so I just...
Are you doing stuff?
Oh, sorry, it's not showing you.
Yeah.
Sorry, apologies. Yeah, thank you. That's weird that it's not doing that. Okay, let's do this. So, what I did was, I clicked upon it. I went to this podcast. There's a free paper here. So, from AEM, get the PDF. And then, just take this PDF and I just literally, as it loads here, oops, I'll just drag it into Evernote, right there. There it is. Retitle it. Hour rule. Done. Now, it's right there at the top of my notes. So I just have that now whenever I want to read it on either of my devices.
Chris, is that taking up space on your phone, or is that virtually stored on Evernote?
It's, I believe, virtually stored on Evernote.
Okay, so essentially when you open it, then that amount of storage is going to show up on your phone, and then when you click OK.
So, Yeah, so it's super easy. So you find a guideline, like I had a pediatric UTI one I wanted to look at the other day. So you just pull it up, copy, paste into Evernote. It's now there on all your devices.
And then you just kind of organize it
And then you can
into
organize
different folders or
into
whatever.
notebooks based on what you
Okay.
want, like talks or passus verbis cards, which are something that are from Academic Life and Emergency Medicine, which are awesome. I don't know if anybody uses these, but they're phenomenal.
Cool.
So they're just they're basically 1 to 2 page cards on all kinds of topics. So LVAD complications, hip injuries, bronchiolitis, ankle, foot fractures. You can download the entire passus verbis cards set off of Academic Life and Emergency Medicine, and then you just have them accessible. And these show up really nicely on a smartphone because they're designed to look like that. So they're for on-shift use. There's like 300 of them now. I think I only have 158 on here. I've made passus verbis cards, the pericarditis one. It's really good if you ever need to manage pericarditis. It tells you everything you need to know about pericarditis management in 2 easy pages. Yeah, so like this is Evernote's super useful. I really like it. OneNote, you can do the same thing. Evernote has like 200 million users, but apparently there's something about how OneNote might take over because it's Microsoft and they'll put more money into it. So maybe, but you can get either one. They're both very similar. You can also do your scribbles, so you can like scribble stuff, take a picture, put it right into Evernote, right? You can also highlight stuff within it. So there's all kinds of other functionalities that I'm not even showing you on these, but I'd recommend you check one out and start having a place that you can store all your stuff for super easy access on shift. So then we'll go back. Okay, so hands-on time.
Do we have to have a Twitter account?
You don't have to have a Twitter account. You can have, but you should have a Feedly.
Feedly, oh, right,
Okay.
Feedly.
Get a Feedly so you got somewhere where you
That's
can
on App Store?
put your RSS feeds.
Okay.
Okay. Or you can have, you should all have a podcast app. I think you all do though, so that's good. So you can follow some new podcasts or anything if you want to. Okay. Oh, and then what I was going to do is if you guys want to get Evernote or something, you want to download Evernote right now, what you can do is you can take that sweet handout I sent you and just copy and paste it into Evernote. There you go, and then you'll have access to it everywhere. So, little foam treasure hunt. Okay. So I'm going to get you guys to go to Foam Search.
So we just open our browser.
Just go to
and
open your
do
browser,
search?
foamsearch.net or googlefoam.com.
Okay.
It'll redirect to the same place. And I'm going to ask you guys you got a tracheostomy patient coming in. They've been trached for a few months. Got a little bit of respiratory distress. Not crazy, not sick, not dying. But you're like, oh man, I haven't dealt with a trach patient in a while. Okay, what am I going to do? So I actually had this as a rapid call when I was working about a month ago. And this is what I did for the doc who was on the other end of the rapid line. I said, hey, go to foamsearch.net. Okay? No joke.
Trach emergencies, emcrit.org.
There you go. Trach emergencies. Sure, emcrit.org. And right near the top of that page, you'll find this nice little diagram in green. You click on it.
There it is?
Yeah, you can see what you guys can find. I'll let you guys find it. You can take a minute.
Oh, here, yeah, bedside
Teach
signs.
emergency, that's what I suppose.
Yeah.
Tracheostomy standing onto the pod.
Yeah. I'll give you the time to
So
see
is
what you
that
can
on the
find.
where did you find
The
that?
encrypt-
Emergency tracheostomy med.
There
I
are-
don't think
there
I
are
have the
multiple-
same one.
Yeah, there are
The
multiple
muscle
different
ones,
pages.
yeah.
Like, so if you are on Foam Search, you're going to find a bunch of different things that say dealing with tracheostomy
Okay.
emergencies.
Yeah.
And a lot of them actually redirect to ultimately get to this point, which might take you a minute. But I told the person on the phone, I'm like, hey, just go to Foam Search, look up tracheostomy emergencies. And then you're going to see an encrypt post, and you click on it, and you're going to see this green diagram. Confirm your patient has a tracheostomy and not a
Oh,
laryngectomy.
yeah, okay.
Okay?
Yeah.
So most people don't have laryngectomies. I actually saw a patient with a laryngectomy then like a week later, and I was like, hilarious. I haven't seen a laryngectomy in like 5 years.
Open up the podcast?
Yeah.
No, just,
And so you don't actually need to listen to the podcast or anything. This is the diagram this is the double-sided laminated diagram that the NHS uses and puts at the head of every trach patient's bed, freshly trached patients. And it tells you basically exactly how to deal with a trach emergency. And you just walk through it step by step. And so I told them on the phone, I'm like, hey, okay, it doesn't sound like the person's an extremist. They're like, yeah, the person has had it for a couple of years, said they're in a bit of distress, seems worse than normal. There's not like frank pus coming out, but they feel like it's thicker. There's a little bit of redness around the site, no active bleeding, setting good on 3 liters. I was like, okay, you can, so do you have an RT? Do you have a suction catheter? You can do whatever steps of this that you feel comfortable doing. Okay, and if things go to shit and you need to do something, you have it right here for you. Then transfer the patient to us, print this out, give it to the ALS crew, and when they get here, we'll take care of them. All right? And to me, like, if I had this, I don't need somebody to tell me all the steps of how to deal with something. I just need to be able to find it. Right?
Yeah.
This is way more useful to me. So yeah, like I've actually used this in practice while talking on the phone.
Oh, I can send it to Evernote too.
And you can
just
send it
forward
to
it to
Evernote.
Evernote right
Amazing.
there.
And then
Boom.
you'd have it in Evernote. So trach emergencies diagram in Evernote.
So then
And so now anytime you need it,
there's a little forward.
or you want to teach a learner, because learners, this is such a great pimping thing. It's like, oh, trach emergency is coming in.
Oh yeah.
What are we
For
doing?
learner. Not a great thing.
What are we doing now? Oh, they're in respiratory distress, they got a trach. How long's trach been in? 5 days. Oh, oh no. No, that would be, don't give them 5 days. Give them give them a nicely, it's been in for 3 months kind of trach. A couple weeks at least. They'll give you one more foam search thing, and I'll just show you. So, because treasure hunting is fun. So let's do just one more. So I want you guys to use foam search and say, where should we decompress chest for pneumothoraces? So,
What is the best anatomical location for
Ooh, there you go.
yeah, so most, I won't put words in your mouth. Maybe you guys all put anterior axillary line needle thoracostomies in or needle decompressions. But 5 years ago, so like you can see a post on Life in the Fast Lane as one of the first ones that shows up. Then there's a great one on Rebel EM that goes through the literature from a paper in 2016.
Oh, there's Arnie.
But from 2014, we knew that probably the anterior axillary line was the place to go in the 4th or 5th ICS, the same place we put a chest tube. And we know that with our obese population that is getting, unfortunately, larger, the chest wall anteriorly is getting further and further away. I actually had a bad trauma from Crow's Nest Pass last week, and I was doing the bedside ultrasound. This guy got like super sick, and it was 5 centimeters from he wasn't even a huge dude. It was 5 centimeters on my bedside ultrasound to the pleural line at the 2nd ICS in the midclavicular line, like the classic place where you put it. There's no way, unless you have like an 8 centimeter angiocath, that you're getting a decompression there, right? And in the periphery, I think that, to be honest, I think you guys probably don't have a lot of 8 centimeter angiocaths. It's hard enough to find them at the foothills, right? But anterior axillary line is like 3 centimeters, 2.5, right? The only problem with doing it in the AAL is that if you're transporting, their arm can dislodge a catheter. But once you're in a stable resuscitative area, it's a great place, especially because you're going to take that arm and throw it up above their head and tie it down so you can put a chest tube in after.
The only problem with this one is you have to read through the whole page to the bottom to see, because initially you look and they say, oh, A, second
Yeah.
intercostal space, and then you have to go down and go, oh, strengths, limitations, discussion,
Yeah.
clinical take-home component. So that's a little, they should have like the...
You need it right off the bat.
You need it off the bat.
Yeah, fair enough.
Yeah.
The point is more that
Yeah.
there are resources
Easy to
that have
find,
been
yeah.
around
Yeah.
for, so now 5 years is when 5 years ago they published this, and I was like, oh, the anterior axillary line makes sense, let's do that.
Life in the
And then
Fast Lane.
it took until 2018 for ATLS to change it, right?
Oh, yeah.
So finally, I actually applaud ATLS for changing it in the 2018 ATLS. That's only 4 years, which is knowledge translation-wise really good. But they could be 4 years earlier. right? So foam will allow you to know things if you follow it about 5 years before most people, maybe 10. So at this point, yeah, I think that everybody should, you don't have to make a Twitter account, I won't force y'all to do that, but Feedly, I think everybody should download Feedly.
Social media presence.
Okay? And then if you're having any problems with it, does everyone have Feedly already? No?
Okay, so how do you use it then? You just,
Yeah, so I'll show you.
okay, so I have it.
Yeah.
I downloaded it.
Okay, great. So then
So you have to make a,
you have to make an account.
You already have a Google account, it's very fast.
okay, Google it is.
Google account.
I get to pick which Google account.
Ooh. Multi-account.
Oh, yes, it's for my international spy.
That's good. I'm
Activity.
gonna go to my Feedly.
Login successful. Personalize, add content.
Yeah.
So just go with the top two
So-
you mentioned maybe.
So if you just go to the search.
It'll be the RSS feed you're going for, or there's a review one as well.
Yeah, so you could just put in like life in the fast lane,
Yeah.
or you could put in foam head or something. But I'd suggest everybody just starts like life in the fast lane.
So that's, you go add content?
Yeah.
Slow here.
Oh, and they have like other ones similar.
And then they have other similar ones.
There's a foam EM RSS.
There's even a foamy RSS feed, which just gives you all of it in one spot as well. But it's actually a lot. Like there's a lot if you use the foamy M one.
Then you touch that one.
It's trying to sell me power search.
Mhm. Stop selling me stupid power search.
Oh, then you hit follow after? Is it the
Dead or invalid feed, what?
create a feed to follow this?
Create, how do you feed name, what? Doesn't the feed name just be like ALIEM, or what would you put for?
Yeah, I put Alien should get you a. Oh, stupid. This is being stupid for me right now
It
too.
says dead or invalid feed.
I feel like it's like in the fast lane.
Is it a picture of a smiling Asian lady on the
Yep, Alien, that's Michelle Lynn,
Just making sure.
smiling Asian lady.
Wait, so then I have this one, do I have that one already? Yes.
Oh, what?
It says I have, oh, weird.
Dude, I feel like I'm old now here. Okay, so, okay, good, then I'm good here?
Yeah, and then
Okay.
if you click on it,
Okay.
now you can see
Do
what
all
their
the
most
stuff?
positive ones. And you can just scroll through and it's got like these are.
I see
Yeah,
your
and
life
then
story.
you-
Or our
Oh, there we
laptops.
Did you find your smart
Yeah.
It's not on just like the.
It's probably like, I looked it up last night actually,
Nobody's even supposed to talk.
because of his badness.
And everybody's just looking at it.
It's now been, I think, like more hidden. I found it on Podbean,
It's not Podbean, but that's a.
but that's a separate thing. Like it used to have its own, like, you could download it,
Don't
just
be a
like
bad
any other
person.
podcast. But don't,
Yeah, you're not.
does everybody know what he did?
Oh, we
We just looked real quick.
Okay.
Conversation, please go to the end between the two.
Yeah, he's very bad.
Tokyo is an amazingly quiet.
I feel bad for his wife, who is also an emerge doc.
Oh.
His wife's Ashley Shreves. I don't know if she's like an emerge palliative doc in New York, and she did like the Annals of Emergency Medicine podcast with him and stuff too. She's like really well known, but he is like terrible. So
That's always associated with.
and now she's always associated with this guy.
Life of. Yeah, exactly.
Life of. So
Wait, like, this is like last one? No.
I feel like an old man now.
yeah.
How do you use that feed?
So in the handout I sent you guys as well, there's like there's links to like step by step how to use Feedly, how to use Twitter, how to do all these things. They're all in
How do I
there.
do that?
So,
Great, man.
and I've checked and made sure none of the links were broken and stuff, so they should be all good. So if you're having any problems, you can just use those.
Oh, they're
So-
all together.
You should have.
So yeah, I'm going to talk a little bit quickly here about a couple other things, and then you guys can, just for time, just so you guys get out of here by 12. Oh, it's 12:30 or 12:45.
Oh, because this is called, there's no ending.
There's no
This is
ending.
not what I want to call
Don't have it.
Never like to go over time. Nobody likes the presenter who goes over.
I'm not reading medicine, so I would call this one medicine. Okay. And then so under this,
How much do you find,
Just
reality-wise, of like looking at this stuff, and going, like, do you find your reliance on looking at phone versus screen, like when you, so when
In reality, how much do I, like?
yeah, like in terms, because what
That makes sense.
the one thing, the same with, I mean, I know it's good and it should, and this is maybe a foolish thing to say, but same with, you know, like order sets.
Yeah.
Like, I like the idea of an order set for, you know, we're all doing the same thing, we're following the same path, you're not forgetting things. But then I also worry a bit about I'm so reliant upon knowing where to find something,
Right.
like my base understanding.
My base
knowledge.
knowledge.
Yeah, so
Yeah,
that's,
for
that's
sure.
my one, like, again, not that, you know, new things are bad.
Yeah.
But, yeah, that's the one thing I wonder about, just because, like at work, where, you know, if I don't know, I will look something up.
Yeah.
But do you find, like, how,
Like, how often am I
yeah, like,
using it?
every third, I mean, it depends on the shift, but like every third patient, every
I would
10th?
say I probably use my phone once, maybe once a shift.
Okay,
So
so
it's something else.
Okay.
Maybe once a shift, and for the most part, it's like, yeah, I'd say probably once a shift. Maybe
Something-
twice.
Something big, or just like stupid like drug interaction things, or like
Um,
breastfeeding thing?
It could be, sometimes, I mean, it can be something that I haven't seen in a long
Sure.
time.
No.
For sure, that I might review something, I might like myasthenic crisis or something.
Fair enough, yeah.
Right? Like
Yeah.
something like that. If I knew recently, like there was a myasthenic crisis patched in.
Right.
And I was like, I'm gonna like double check myasthenic crisis, and so I pulled up my phone and
Okay.
checked it out and just used the FREM review chapter on myasthenia. And I just went through it quick, just like 2 pages, and I was like, boom, I'm like back up to date on myasthenia.
Okay.
So that's what I used it for.
Okay.
So I use it for things that I don't see often, and then I use it for little things.
No, interesting.
Yeah, and there is definitely as much as I'm a proponent of foam, this is kind of the part where we talk about the integration and should foam have a curriculum and stuff, because I fully believe, I think that unfortunately using order sets that guide you through everything very simply like we do in Calgary, and not having med students, if you do all your training in Calgary, I think it unfortunately, sorry, I did family medicine in Calgary, but it makes you kind of not as smart. Because you have a reliance on order sets that are evidence-based, that you can just click boxes, and you've never written a paper order in your life. And so like when I have learners, I say, I want you to write up the first 4 hours of DKA management on paper and give it to me, right?
Nice.
That's what I do. I say, I want you to write out all your tests. No, you don't get to use SEM. You just write out all your tests. Like, give me the paper orders for everything you do today. And because if you can't do that, you don't really know it, right? And so it's like, if you had to, there's a lot of stuff that we do that you have to know right now. And if you don't know it, that's a problem. But there's also, on the converse, the other end of the spectrum, a ton of stuff that is not necessary to know, but it's necessary to know where to look it up quickly. And the concept of not embracing the fact that we have the technology we have to, make our lives easier and make us have to remember less things seems quite silly, right? So there's a balance. You need to have the foundational knowledge, but you shouldn't be remembering a bunch of esoteric stuff, because why? Why would you? That's brain space that you can use for other things. So yeah, so then we get into the foam curriculum. So the question is, should we have a foam curriculum, right? So everybody's using it. All these residents are using it all the time. 90% of them are using a blog every month and 86% using a podcast. So this is controversial to me, because the essence of foam is that it's this completely asynchronous learning style, right? It's that you're learning what you want when you want. And it doesn't have a curriculum, because foam typically doesn't focus on the unsexy topics of medicine. Although, to be honest, there's more awesome foam about UTIs than you can imagine. And goddamn, knowing that just symptoms plus young female equals a likelihood ratio of 24.2 means you don't have to do any tests, right? And that's great stuff from first 10 EM. That goes through just the nuts and bolts of every likelihood ratio for every test that you do for a UTI. just boils it down super nice. Like, that's great. But the unsexy topics are not covered in foam with nearly as much as the sexy ones. Airway, breathing, circulation, trauma, sepsis, blah, 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 right? So, should there be a curriculum? So people have tried this now, though, so that's good. So if you want to help guide your learners or guide yourself or whoever on where to learn more complete style using foam, academic life and emergency medicine, because they're very much more like the academics of emergency medicine. Like, they're all people who have professorships at big universities and stuff, right? Teresa Chan and Michelle Lin and stuff. These are big emergency medicine educators who spend 60% of their time teaching, probably work 4 clinical shifts a month, right? So, what they did is they made this project called the Approved Instructional Resources Project, which is educator-endorsed listings. So they got a bunch of program directors for emergency medicine programs in the United States and Canada, as well as emergency docs, and they go through foam resources and they review them. And they say, these are the good articles, all the good foam resources, such that you develop a complete approach to genitourinary disease or trauma or whatever. And then they did this partially because they knew learners were using it, and partially because learners were using it and not getting credit for it. So now there's over 125 emergency medicine residency programs in the US that use this, and like 1,200 emerg-med residents. And so what happens is, this is just a sample of them, but like there's 26 modules as of now, and you click on them, and it gives you all the foam resources that they've gone through and they think are good for that topic. And it gives you a suggested number of hours that you spend on it. And then there's post-evaluative quizzes that you can use for credit towards your residency. Yeah, so these are fantastic.
So is this free to sign up?
This is all foam, man.
Yeah.
It's foam. So you could now, with their 26 modules, you could probably learn a large chunk of an emergency medicine residency in a pretty complete fashion. And to be honest with you, have I reviewed some of these modules? Hell yeah, they're good. Like, it just shows me all the good articles on the topic. And so, well, finally, last thing, we'll talk about quality. So the most notable critique and caveat of foam is, what is the quality, right? And prior to discussing it, or now discussing it, the most important thing I think that we need to realize right off the bat is that FOAMed, the people who produce this stuff, the content creators, are generally the people who would often be our very respected colleagues when we work. Like, you'd be like asking them questions when you're on shift about patients, and they're doing it out of the goodness of their hearts and love for education, and not because they're trying to misdirect people. They're not getting paid for it. They could be working shifts and making a lot more money. And they do this because they're like, they believe in it and they think it's useful. So I think that like that's a very good place to start. So quality control. So we have 3 groups: the learners, the teachers, and creators, right? Learners are obviously the most vulnerable group. So this is the problem of if you don't have any foundational knowledge and you start with foam, you're at high risk of having huge knowledge gaps and doing things that your preceptors will think are crazy. Okay, so problem. And there's also regional differences in foam. Like, for example, if you had some learner here read a bunch of US foam about chest pain evaluation, they'd want to admit everybody. But if you have learners who go and they read all US chest pain foam, they're going to come back to you like, well, we got to admit this patient with all the 18 negative troponins because their story's good. But I did it. They've had chest pain for 7 days. Yeah, so the next group is the teachers. So that's, to be honest, going to be most of you guys in the room, right? You're not, you're kind of, I think, in the learner/teacher role at different times right now, right? And so the teachers, what's important is that coming out of this talk, I hope that you guys have some things that now you know and you can direct learners towards, right? If you're learning, now you have some things to learn, but also as a teacher, when you'll all be teachers at some point, you can direct your learners towards good quality resources and have some knowledge of what's out there. And every community of practice needs local champions. So be a local champion, okay? And direct people in the right direction.